paid back in his quarterly supplemental rates. Okay, a few other things rate-wise to go over. One is provider payments, and what provider payments are is medical services to nursing homes, mid-level, home health, home support residents not covered as part of routine services. So these are things paid outside of the regular rate and administered by the Office of Medicaid Business and Policy. What this means is, let's say your nursing home provides some sort of clinical services that's not part of the routine care. That could be billed separately. The major place where this comes into play would be pharmaceuticals. Pharmaceuticals are not part of the regular rate, and so you're getting your rate, but you also get an additional amount for the pharmacy. Any other expenses that would not be part of regular nursing home routine service, you could bill separately and receive a separate payment for it. That's what provider payments are. So that's additional billings. And then lastly, I want to spend a little time on prospective share payments, or pro-share. Pro-shares only for county facilities. The payment is made in June, the final month of the state fiscal year. And what this is a calculation between the difference between what the Medicaid rate paid was and what the Medicare rate would have been for the same resident. And this gets a little confusing because the facilities say, well, that's not what our Medicare rate is. Well, no, what their Medicare rate right now that they're thinking of is what they're being paid for their Medicare residents. This is not the Medicare residents. These are the Medicaid residents. What would these Medicaid residents have had for a Medicare rate if they had been on Medicare instead of Medicaid? This is a federal loophole that allows a payment to be made annually that shows the difference between the Medicare and the Medicaid rates for these Medicaid residents. You're actually going to be paid not that variance, but essentially half of that variance. Because this is Medicaid, which is a federal matching program. So essentially, when you figure out what the difference is between the Medicare and the Medicaid rate, half of that would be considered the county match. So you'd get paid from the federal government the other half of that.
And county facilities are the only ones that even can benefit from this extra payment.
How did that happen?
Yeah, that's been that way for about 8 years now.
Is pro-share going to continue? I keep hearing rumors that it's getting less and less and probably would be
You know what?
eliminated.
Those rumors have been around for 15 years. What the federal government will decide to do, I don't know. This is an area, pro-share, like provider taxes, an area that the federal government would like to limit. The current administration would like to limit those. Well, the previous administration wanted to limit those too. When the provider tax went from 6 to 5.5%, that was when the Bush administration actually wanted to change it. They wanted to make it in half. They wanted to go from 6 to 3%. And the most Congress would take it down was 0.5%. They weren't going to cut it in half. They just took it from 6 to 5.5. They've actually since actually gone back up to 6, but New Hampshire has chosen to keep it at 5.5%.
Why?
Why?
Why? Well, because you have some private nursing homes, continuing care retired communities, as well as other private nursing homes that do not participate in Medicaid, that still have to pay this assessment. So they're paying the 5.5% tax and receiving back no benefit because they do not take Medicaid residents.
So they have zero in an input payment that goes to them, but they're still paying the tax in.
Right, and last year, the Republican legislature made a commitment to New Hampshire not to add any or raise any taxes. And for these private facilities, it would have been a tax increase that they received no benefit from. And so that's why there was actually legislation last year to raise it back up from 5.5% to 6%, which the House Speaker and the Senate President then effectively killed, because it would have been, for the small number of facilities that do not receive any benefit from this, it would have been a tax increase. So when you make a firm commitment to no tax increases, you stick to it even though the majority of the facilities would have benefited.
And how does the DEAS line item factor into this, the $3 million that the county puts up? Are you familiar with that at all?
I'm not sure specifically which thing you're referring to.
DEAS, yeah, we're close to 4 million, is it?
Yeah, it's like 3.8. I don't know what the acronyms, I forget what it stands for.
Yeah,
Elderly and adult
3,959,000.
You,
Elderly and adult services. Is that what it is?
That's what the acronym is.
yeah, you say 3 million, is that what you're referencing?
Yeah.
Oh, okay.
3,900,000.
You're talking about the county cap, which is a payment that you make.
We're going to go into that
That's
as well.
a different process
We're
than this completely.
going to discuss that also today.
So the county cap is actually payments that you make to the state as
That's right.
opposed, and so that's where those credits are going against, is reducing how much payments the county would have to pay the state. It's outside of this assessment of 5.5. It's outside of the nursing facility rate process.
Okay.
It's a separate process.
Right. I'm starting talking about all the Medicaid fundings that we pay to you as the owner of a nursing home in the county. We'll then get into what the counties pay the state as a payee.
Okay.
That's the second part of this. I don't want to blur the two.
All right.
This is a lot of technical information, which is why we gave you the handouts. So yeah, so that basically this is a payment made in June. It's calculated as a half the difference. Okay, on the final page, you basically explain that essentially what this is. You've got your Medicare payments, less any Medicaid payments, less the acuity, the MQIP, and any ancillary, and the end is the net county facility amount. So that's the first part of today's presentation, the longer part, on how nursing homes get paid for. I know this is a lot of information. Before we move on to what the counties pay and the county funding and county billing and all of that, are there any questions on this part?
Wish I knew what questions I had.
Well, your
We have a good administrative staff at the nursing home that
Yes.
understands this fully, so I'm sure we get,
they do, and I
Benefit.
made a presentation about a year and a half ago at your annual meeting, a year ago, October.
Yes, you did.
On this.
I remember that.
Oh, yeah.
I also made a more detailed presentation at the New Hampshire Healthcare Association's annual meeting a month prior to that. Some county administrators attended as well. I'm not sure whether yours did or not, but I'm also willing to come out and meet with any business office or administrative staff that would like to go over this in more detail. I'm willing to do that. I've done that before. A prior administrator, Mr. Froten, and I came out a couple of times to walk him through this and input as well. And I'm willing to do that again as needed.
Thank you.
I had just one question. I had heard that there was going to be some change to either this process or the DEAS process in 2014 when the Affordable Care Act kicks in.
Well, can I just talk about?
Go ahead. It's all yours.
2 comments I guess I would like to make on that. The first comment, which actually even is sort of predates 2014, is the state of New Hampshire is undergoing a Medicaid reform currently. It starts this July 1. We're moving to what's called a managed care system, which we can come talk about on a separate date, which is really changing the whole environment of the Medicaid process. It was passed by the legislature last year, requiring the Department of Health and Human Services to institute a managed care system. And generally speaking, there's a lot of federal guidelines to this new program, and it really changes the care delivery to any Medicaid patients or Medicaid only. And it involves managed care organizations to help run the program. The first phase of the program goes live this July 1, which is primarily around, I'd say, primary care medical services to Medicaid patients. Next July, so July 2013, is when the long-term care services and population related to those services come into play. So there may be some changes to the rate setting process in July 2013 when the state moves to that phase of the managed care system. So what that does is it takes away a little bit of the state's rate setting process in terms of medical payments that are made to providers, to facilities. They're going to be actuarial set rates and rates negotiated also between these managed care organizations and those providers directly. What we're unsure of is how that process may work in a year from now in 2013. The first phase that's happening in a few months, those managed care organizations are working directly with providers and negotiating rates. So the state has a little bit more of a backseat. We can approve those rates, but we're not the rate setting body. For 2000, the next year out, when it comes to long-term care rate setting, we are just beginning that process of, do we want to look at the rates? Do we want to keep those rates internal? Do we want to work with these managed care organizations in the rate setting process? You know, that's really unknown at this point. I mean, it's granted it's a year out, it could be here before you know it, but we have a little delay before we hit that point. And as we move into that phase 2, we're going to have numerous stakeholder meetings with both providers, with clients, with the organizations, to say, look at our process. Is there a better way to handle it? Is there ways that we're doing really good that we want to maintain? We're going to look at that process as we move down that road. So then 6 months after that takes place is really when that 2014 ACA comes into play. What that the ACA is going to do, the way it looks today, is it expands the Medicaid population. That's primarily what that is going to have an impact in New Hampshire. It's going to add recipients to the Medicaid program. And we are also trying to, figure out the impacts of what is that cost going to look like, how many people is that going to bring into our Medicaid population. We currently statewide have about 150 to 160,000 Medicaid residents, or Medicaid patients, I should say. We're trying to look to see, ACA may bring in 30 to 50,000. We saw some numbers in addition to that, but that's really preliminary right now. So I would say two things is that it's a little unknown of what it's going to look like, what the landscape's going to look like in 2014, but even prior to that, we have a state managed care Medicaid system that's evolving. That has nothing to do with the ACA and where that's going to be.
What is
managed care?
Yes.
Managed care, it's two ways to look at it. It's, or in other words to look at it, is a care management system. It's really looking to try to better coordinate care and services to Medicaid patients. And I say care coordination as a primary aspect of the program, in that you want to start being able to have a person that's getting maybe, you want to eliminate duplications that are happening. You want to make sure that you have primary care physicians that are talking with perhaps a behavioral health specialist if that resident is, patient is having. You want to be able to eliminate maybe emergency room visits. So if you're working more on preventive care, maybe you're eliminating those high-cost emergency room visits because you're working more on a regular basis with those residents. You're really trying, I think what I look at it is managing that care for that individual as best you can. And so it's not just looking at, right now the system is really, it's a fee-for-service system. If a patient needs to get services, we pay that provider every time that person goes in the door. And it doesn't encourage or provide incentives to say, is that the best care? Do they need 10 visits? Do they need 20 visits? Have they gotten the same visit more than once and they've gone to this provider and then they've turned around and went to this provider? And so we're really looking at a way to manage the system in addition to managing that care for the patient. And so there's organizations out there that are called managed care organizations.
That was where I was going.
And they're MCOs, is the acronym for that. An MCO is a managed care organization that then becomes on the hook for not only making payments to providers, but also managing the care. If you think about, sometimes you have, another buzzwords out there might be, you have case managers for individuals, You have care coordinators for individuals. You hear some of those terminologies when they talk about a managed care system, and it's really trying to coordinate in that service that person needs.
And this managed care group,
Mm-hmm.
is that an insurance company?
It doesn't need to be. I mean, there's certain requirements. I mean, there are certain insurance requirements that they have to be able to take on risk in the state, but they don't have to be, you know.
It's not going to be a contractual agreement with
Correct.
Health and Human Services?
Yep, and what it is,
It will be?
actually, we just in October, around October 15th
I
or
thought
so.
the commissioner was trying to reduce the number of contracts that they have throughout the state
Yep, and
and try to
yeah.
bring those down into a management level.
We are doing that as well. These additional contracts replace, for example, we will no longer have the need for provider contracts with direct providers. What'll happen is the state will have a contract with a managed care organization. So, and then that organization is responsible for the negotiating the rates and working with the providers.
So you're adding another level.
We've added a layer, but we've also eliminated a
Individual,
layer
yeah.
in an individual. Just to back up for a second, is the legislation that was passed last year required the Health and Human Services to issue an RFP for this program. That RFP hit the street, I think, October 17th of last year. The feds also have to approve the program before it can go live, so there's a lot of steps that have to happen in addition to the state process. The feds require a minimum of 2 MCOs to be part of your state program. We currently are looking to have 3, so it also allows individuals to have choice. That's really important as part of the care management, that an individual in a Medicaid program is not restricted to one organization that they have to deal with. So we're looking to have 3. We went through a bidder process. Bids were due back in December. The department has been working intensively since then on reviewing the proposals that have come in and are working on contracts. The contracts right now are slated to go to Government Council for review next week. So this is a very new and sort of hot topic that's taking place right now.
So we won't be looking at something like went on years ago with the HMOs, where they said, no, you can't have that procedure because we just don't want to pay it?
All right, I would hope that is not what's happening.
Yeah, well, me too.
And then, obviously what you really want to have is better care. I will say though that the feds are actively involved in the Center for Medicaid and Medicare has to approve any state plans that have gone this way. Most states have this already. We are a state that's lagging in the development of a care management system. So we're not the front runner by any means in moving towards this. I will say in terms of procedural is that there's several levels of grievances and appeals that we've also put into place, both from an individual provider level, a client level, and it's not just that it stops with that managed care organization. There's also a process for the client to hit after a managed care process that they've gone through. So it's not just they have one avenue to sort of appeal something, let's say. There's a further appeal with the department. So the department is actively involved in that oversight, and hopefully maybe that, eliminates those issues that may come up. That's our goal. So it's a little long-winded, but I wanted to, if you hadn't been part of any of the managed care discussions, wanted to just let you know that, that's a new, it's probably one of the largest initiatives that the department is taking on in terms of the Medicaid program. And, as we move into phase 2, which is going to impact you potentially impact you the most in terms of long-term care costs, that's July of 2013. And, we'll make sure we continue to reach out as stakeholder meetings and stuff like that occur. We'll go to that.
Is all this going to save the state money?
We hope so. That's our goal. So in terms of the rate setting process, I mean, it's gonna look like this today. It's gonna look like this at least a year from now. Under a new system, it may look exactly the same as well in terms of how the rate setting works. Where it's a little too soon to tell where that's going to head.
Okay.
Say the state can pass it down to the county.
Before we get into the, just because we've been here, kept you kind of an hour, what Jonathan has really focused primarily on was the revenue that you receive from the state for your Medicaid population. As we mentioned, there's a whole second piece to the Medicaid system in that the county is also responsible for paying the state for some of that cost. You can call it a sort of a county participation in the cost. And there's a process for that. Now, we can either get into that today, we can kind of continue on a little bit. It's not nearly as lengthy as the other presentation, but just because we've kept you a little bit, I wanted to just check in with you to see if you want to kind of want the 30,000 foot on that. What level do you want to get into?
Yeah, let's go the short way.
Okay.
Okay, well, basically, counties have always participated in the Medicaid program. Up until state fiscal year 2008, the counties participated in a wide variety of different programs, most of which they paid 25% of. And this not only included nursing homes and home care, but the counties also participated in juvenile justice, in children, youth, and families, and then there were other long-term care-related costs, the aforementioned provider payments, any Medicaid-funded hospitalizations and physician visits, anything of that nature was funded, and then even aid to the needy blind. There were basically 9 separate categories that the counties participated with the funding of. And the approximate cost of all of those to the counties was around the $95 to $100 million range. In state fiscal year 2009, that changed. And the New Hampshire legislature changed the funding to a different system, whereas all of the juvenile programs and all of the ancillary elder programs became 100% state funding of the non-federal share.
That was an agreement with the each of the counties
Yes.
and the state.
Yes.
But there was a cap set.
A memo of understanding was created, and that the counties then would participate funding all of the 2 remaining programs, namely nursing homes and home and community-based care, now referred to as Choices for Independence. That those 2 components, the counties would continue to pay for, and they would initially pay all of it up to a cap. And once they reached that cap, it would stop, and any expense over and above that would be borne by the state.
Right.
And that was originally perceived as a way of limiting the county's risks, that the counties would be able to budget, and they would know we're responsible for X amount, but no more than that.
Right.
And there's been a lot of questions as to the specifics of how that cap is set and how the credits are done. And I received several phone calls from one of your representatives, Representative Babson, who wanted me to walk him through these processes, and I think I have to some degree.
Yeah. This came up a little bit on Monday too.
Okay.
What happened to the cap?
And so we want. Do which one? We can do 12. That's fine. Okay.
And as we get into, as John was handing this out, what we brought was the calculation of how the 2012 cap was calculated, and the cap number that Chair, that you had just mentioned, 3.9 million, is the amount that Carroll County is responsible for paying back to the state for state fiscal year 12. And what we can talk about with this is, in terms of the law, I just wanted to just do a high level here, is that the law itself sets the total statewide county cap amount. And that statewide amount is $105 million for state fiscal year 12. What the legislature has done is, in addition to that 105, it said we will also do a credit against that. And that credit is currently $5 million. Sometimes it's called the targeted credit. And so then it instantly brought down the cap statewide from 105 down to 100 million. So counties would only have to, now that's statewide, we'll get into your specific, down to 5 million came off the top, right there, as a way to reduce county obligations. This past year, this past budget, an additional credit was also granted. So the 5 million, the first target credit, has been in law for at least a few years. Knowing that they were making some changes, for example, to the 75-25, they were trying to, they being the legislature, was trying to find a way to lessen that impact. So they issued an additional credit this year, which was about 2.5 million. The exact number on the handout is 2,498,000. So that brought down the total statewide obligation from the original legislative amount of 105 down to 97.5 million. Once again, like I said, if you looked at fiscal 11, it was 105 minus only the 5. So now they've done an additional about 2.5 million against that as well. So that 97.5, that is a legislatively set number that the counties are required to pay. The complexity or challenge that comes in is what's each county's share of the 97.5 million? And that's what the rest of this handout gets into is, you know, how do we split up the 10 counties to say, you know, what's Carroll's share, what's Coau's, what's Hillsborough, and there's 3 different mechanisms for determining that to get to, for example, Carroll County share is 3.9 million of the 97.5 that the statewide all the counties have to come up with.
Right. Now the sheet in front of you, the top page, page 1, is the summary of the whole thing. The 4 pages that follow are the specific spreadsheets that make up the components of the different columns. So to get, how did you get to this, how did you get to that, and so on for the different sub. But to begin with, for a high level, I just want to briefly walk you through the front page, and then we can get into more detail on any of the subcomponents if you wish to.
But somehow or other, the cap was changed. It was increased or extended. Because we're paying a lot more now than we paid before.
The county cap has always been in law, at least for the last 15 years, probably longer than that. And it is changed with every biennium budget.
Mm-hmm.
For this particular one, the cap nets out to the 97.5 million. How that gets distributed among the various counties depends on these different components.
And if you want, the law of reference is RSA 167, section 18-A. And that RSA will talk about what the cap is. It goes out to 2014. It has 2011 through 2014 in the law right now. But as Jonathan said, that has been in place. 105 was the same cap that the top base before the credits were applied, was at least in place for 11 and 12. I'm not sure what it was in 10, but 11 and 12, that 105 had stayed the same. And then once again, the credit of 5 million has also been in place at least for a few years. And then the new credit was the 2.5 that just came into play this year. One of the things I was just going to say is that some counties, what we said is what's really changing is maybe the split between the counties. Right now, Carroll County has about 4% of the total of the 97.5.
Right. We're the lowest. We're the lowest out of the state.
Correct.
Yeah.
So on the flip side, if you were Hillsborough, you'd be paying close to 30% of the total. They're going to, a different size. Yeah. But one of the things, I don't mean to jump ahead of Jonathan here, is one of the things that really drives this, which I think is important to note, is that every year, the very first piece of and it's the primary factor, I think, in setting this, is your actual 3-year average of your claims, of your Medicaid claims that go through the system. So you take a 3-year average of your actual to determine really that breakup of, what's your share. And if you notice that very first column B, if we just looked at your 3-year billing average, you're about 4% of the total ends up being in your share. After credits and stuff, you're at 4.061. It doesn't vary that much between after all the credits are applied.
Yeah.
But the 3-year billing is really, that's really what's going to drive your share. So if you have higher costs than other counties, that's going to go, that may change your 3